heart of our conference, where ideas meet action. We now move into a truly special segment of CAHOCON 2026, session that explains about the moments that matter in healthcare, stories of care, healing and trust. In a world of SOPs, KPIs, checklists, turnaround times, the session is a gentle reminder that most important metric is still human touch. In healthcare, beyond protocols, audits and accreditation, it is these very moments of compassion, connection and courage that define us. Do you agree with me, Mr. Abdul?
Absolutely, Dr. Aditi. These are the stories that stay with us long after reports are filed and shifts are over. The stories that remind us why we chose this profession. May we have the honor of inviting Dr. Ravindran Jegasothy, Senior Consultant, OBG and Councillor, MSQH, and Dr. Arun Palaniswami, Executive Director, KMCH Coimbatore.
I'll just request both our chairpersons to please kindly come on the stage. Dr. Ravindran Jegasothy and Dr. Arun Palaniswami. We welcome you on the dais to our esteemed chairpersons.
To discuss on clinical grand rounds, the healing touch. Now we take privilege in welcoming our first speaker for the day, Dr. C Palanivelu, Chairman, GEM Hospitals and Research Center, Chairman. Our next speaker, Dr. Mathew Cherian, HOD, Interventional Radiology and Imaging Sciences, KMCH Coimbatore. Our third speaker, Dr. Biju George, Director and Professor, Department of Clinical Hematology, CMC Vellore. All the three eminent speakers will be discussing on what 30 years at the bedside has taught me. That's by Dr. C Palanivelu, Chairman, GEM Hospitals.
I'll just request our esteemed chairpersons and speakers to please be seated on the stage. I just request the audience that we are starting our session to please settle down quickly. And I am very sure and I'm promising you that this session will be quite engaging. So I'll request everyone to please settle down quickly.
The floor is yours. We request Sir Dr. Ravindran Jegasothy to take up the session.
Good morning, everyone. Good morning, everyone. Welcome to our session. This is from the bedside teachings from eminent doctors. We've gathered 3 eminent doctors here today, and to send you a listening audience. We cut the sound. Okay. Anyway, we're about to start our session. We have 3 eminent doctors here today, each one with their own message of bedside teaching. We'll start with Dr. Palanivelu. Dr. Palanivelu is one of the fathers of Indian laparoscopic surgery. He's won multiple international national awards. He is the founder of GEM Hospital. He's also an author of a recently titled book, Guts. Please welcome him all on stage and give him a round of applause.
Thank you very much for the invitation. Good afternoon to all of you. And I think this is a topic given to me, something is to my heart. And we are in the stage of modern era. and surgical or medical, we have the highest technology possible that for diagnosis, for treatment and everything, communication, all we have something in different way. So three things making a difference between the past and now. One is, you all know, and it is artificial intelligence dashboard. And we are also that more important is remote monitoring. Third is medical legal problems now. So these are the three things making a difference between the past and present. But meanwhile, before taking up, I don't know how many of you may be here, the young doctors are there, more of them. So to look back, how much bedside examination or attachment to the patient relevant, looking my own way, why I became doctor, look at my own kith and lovable younger sister died on my lap when I was doing 8th standard. She was 12th standard. Why she died? She was suffering with pneumonia, but no single doctor available in my villages, so she died. That day, I should become a doctor to take care. That's the way my decision came. Later, I was doing MS at Madurai. I saw cancer patients are all coming and going without treatment. That also made me to look at, okay, why not become a specialty like that? Was the reason. I realized something connection between the patient and the doctors, that is much more relevant today. That's why I took it up. And those days, no computers, no data entry, and we don't look at anything making it something look for Google or this. So we have to look at the patient, talking to them, find out the problem, and taking. That was the only thing available with us. And the days used to go rounds individually. Not even staff nurse will be coming. So we have to examine, touch the patient, asking them what the problem. Accordingly, we take a decision, investigate. And later came, and number of patients when we started looking more. Staff nurse used to come and help us because they'd be very busy taking. Number of staff, very less. Even now it is less. Those days it was scarce. So they will not come for rounds. Whatever instruction they will carry out. 24 hours staff nurse look after the patient. Later, staff nurse used to come, and after some time, and that demand was more, and the secretaries will come. Why? We have to keep records, we have to keep data, we have to speak to them. We don't have time to talk. So secretaries will talk to the patient making records, and the treatment goes as per the data, records and everything. It is not the disease period oriented. Later now the secretaries also less. Want of secretaries. Now after some time we have to look at some robot will come with us with the rounds. The robot is going to tell this patient has this problem, this is what need doctor, do like this. Sometimes we miss, no doctor, the patient already told this one. Instruction, guidance going to come from robot sometime later. The feel between the patient doctor is going to disappear. That is what I personally look at. But clinician must be a true clinician. For example, unless until you know the patient's problem, we cannot. For example, I can quote one example. If you go to Madras Medical College, there is Guruswami Mudaliar statue. Why, such a great clinician. For example, one patient came to him with a headache, and he asked a fees. She was wearing a diamond because very rich lady. You give me the diamond, I will treat you. That lady removed and gave it. If my headache goes fine, and diamond is not a problem, so he gave it. And then asked the patient, come tomorrow. Next day the patient came, doctor, my headache disappeared. Then why no? He understood that reflection making headache. He asked them to remove, that's why he asked a fees. Next day he wanted to give the diamond back. You can go here after headache, don't wear. That lady told, the diamond is your fees, and please keep it and belt back. So such a very important is more. Even rounds walking, many surgeon goes without a stethoscope, don't touch the abdomen, and casual talking coming back. That is a trend now. But those days, we go, talk to the patient, touch the patient, find out the abdominal problem, simple. Even looking at the face, clinician used to say, this patient have problem. And if they are comfortable, or you're not comfortable, what is that? If suppose lab call is done, laparoscopy, by looking at you and so bile leak must be there. And some surgeons not even looking at talking nowadays, asking ultrasound. Finally, ultrasound also may not say there is biliary. Patient also get discharged. After 10 days, 15 days will come with bilioma or peritonitis, fever, running. So that bedside examination is the most important thing. however investigation technology you have, more important. Sometimes nowadays daycare, patient coming getting a minor surgeries, no Foley's catheter, and patient will complain pain, and doctors are without touching the patient will give analgesics. 4 hours, 5 hours, the bladder will distend up to the umbilicus. Then staff nurse, sir, he has not passed urine, sir. Then putting hand, bladder distant so much. Then put a Foley's catheter, the patient has to suffer urinary infection. So clinician know what is the problem, accordingly treat rather than the problem, more important. And the second thing is, patients do things today we have to. They are ignorance about health. Second thing, they are also not about the disease. And that's why they used to call, ignorance is worse than the disease. Suppose if you say cancer, that means they may not know about the cancer. They know only thing it is cancer means end of life. That after death when he comes to know. But we have to explain them, it is incurable, something like we have to go. Time is there and I will show that. So most important thing is explain the patient to understand the disease before attempting any treatment. You, surgeon might have done a complete cure surgery RO, but if you don't understand the cancer, going back somebody says, you had a cancer, this is what, our people always misguide the people, that day enough, and you have done curative surgery, but patient goes in depression and takes off from routine life, but no problem. So that way look at protocols, certain protocols will come, and very difficult to say, you have to look at individual patient. And the corporates today is most important things, and they have protocol, doctors have to do it, but the protocols may not. For example, 41 years old male and fell down with giddiness, and then later found out his hemoglobin was 6.5 and he has got a cancer in the esophagus, and UK they telling your treatment is chemotherapy. This guy with the Google or friend's voice saying it is signal chemo may not respond, what to do? And if you give chemotherapy become advanced, my life is, that is your luck, you have to live with that, you know. With the cancer, how can he live? He has to die only, no? That particular patient came from India, they operated him and completely removed, no nodes positive, and he is back to normal life. So protocol, sometimes you cannot take it generalized. We have to talk to the patient, what is the problem? Patient is willing to accept risk we have to go through, that's why life is more important. Second thing, we have to talking, making the more. One of the patient was wanted to undergo surgery, but the cirrhosis liver is a problem. Surgeon says cirrhosis liver better not operate, risky. Risky, no. But if it's the early cancer, curable, but cirrhosis liver also is treatable nowadays. You cannot go say no treatment to any patient. But people understand, if you explain them risk, yes. For example, I want to do a robotic pupil operation. Robot instrument going, cirrhosis liver, entire audience and experts say, better leave it not to take risk. I said, why to leave? This kind of treatment is going very well. Then I showed them how laparoscopic robotic pupil can be done. Pune, it was done in front of a conference that was done in 2016. That patient lives comfortably till now. So surgeon should have a boldness, courage and operate certain risk. But provided we have to explain the patient, proper consent must be there, and relatives understood, we can go ahead, that is very possible. And certain diseases patient will come some symptoms, may not have, the disease may be different. And if you look at symptom treated and the record data, if you send, the patient will have to come back with some other disease at once. So we have to talk, identify, but proper explanation, patient will accept to undergo treatment, and in that way we cannot ignore that possible way. Very important thing. But today, our Vice President nicely spoke about mother tongue, the way explanation is. It is true. And today, doctors are coming from different places, language different. So somebody know language, understand the people, proper explanation, mostly there. And if you say risky, you will die, then no point of operating it. But should give confidence. And if whoever doctors, the people have got a faith and trust, then only they will undergo treatment, otherwise they may not take accepted problem solving. And nowadays, many diseases come. If you think diabetes, if you think obesity, you tell a patient obesity will get surgery, they will not. But proper explanation, they will agree. Because it is not the surgery before 20, 30 years before. Now we are able to treat. Diabetes does not mean it is a incurable disease. Diabetes, type 1 fine, type 2 is curable. So patient comes to you, you have to talk to the patient, explain and investigation, and then they. So the art of communication is the best thing in success of anybody clinical practice. And if you talk to them and convince them, that will undertake possible. And sometimes communication is not very difficult. Even research, everything, patients tells us to do something, that's the best way to go through. And doctors who comes to us with the explanation, asking us doing it. Some people goes to Google, coming and asking repeatedly something they could not understand. We cannot get irritated. It is natural, they are ignorant. You have to convince them and getting it done, that is much more important. Right? And another important things we should look at is, any surgery, any disease not to primary, whether surgery or not, explanation of this, about the treatment, subsequently how it will be, possible complication, how much you concerned about the patient. That confidence we don't create, it becomes a much more problem. And if you have a bike, you have a car, you say FC when to do service, how to do it. But if you are doing a surgery may be successful, patient goes home. After some time, proper follow-up is not there, then it is very difficult. So that's where also our concern is there. And I used to go in the evening rounds in those days, 20, 30 years where I was alone. Evening rounds, if you go after the patient looking at, smile, that happiness you can see something beyond. Touching the patient is still more. So touch and that feel and talking your concern, that makes a difference. Today, I'm young surgeons, I'm seeing they are very busy, shortcut, they want to jump, they have priority something else more. That's why the people are more of the time they complain and make it up. So today, bedside examination and seeing a patient, there we get more happiness rather than just like even, that's why I don't look at fees, what is the patient paying. The smile when the patient leaves home, that smile is the greatest award I consider. That's why I look at the youngsters also, that should feel how much the relevance is going to be there. Very important is touch, feel and concern with the patient if it is more. Even a major surgeon doing it, some problem happens, patient will not complain, they know. For example, one patient, I did a Whipple, open Whipple those days, and seventh day patient about to get discharged next day, talking casual, everybody knew. But some drug complication happened, and it is not because surgery, they knew. And none of the people complained. They said, doctor, you did the best, but it is unfortunate hours. None that way went in. So today we have everybody look at their own and patient relation. Doctors, I consider doctors are most gifted in the profession among all these. And beyond money or not immaterial, their love, affection showing the people to us. I don't think anybody can come on can get it. Wish you all the best and take it up. Bedside examination is considered the basic foundation. Any technology now or future that is going to be made successful. Wish you all the best. Thank you very much for the opportunity given. And CAHO, greater meetings, very nice and everything.
Thank you, thank you. We'll take questions later, I think in the interest of time.
Audio team, there's some severe echoing on stage. It's making it hard to listen.
Can someone just check the sound system?
Yeah.
While that goes on, we will proceed in the interest of time. First of all, let me thank everyone for being patient and listening intently to the discourse that's going on stage. I now would like to call upon Dr. Norman Chandra Bora, who is the founder, chairman and managing director of GNRC Hospitals. He's going to talk on an interesting topic. We have heard about many leadership journeys over the last few sessions. He's going to talk from bedside to boardroom, a neurologist's leadership journey. Let's listen to him over the next 10 minutes.
சார் இது மாற்றிருக்கீங்க யார் மாற்றுறது போடியம் போயிட்டு
Okay, I think there has been some confusion in the topics given to us. We will like to invite Dr. Biju George, who is from CMC Vellore. He is going to talk on another particular interesting topic here. I think he will himself introduce the topic. So in the interest of time, I think we have to move on.
Thank you very much, and to start by thanking CAHO for inviting me. So what I will do over the next 10 to 12 minutes is to present a few clinical vignettes of how we've used both outcome measurements and accountability in our clinical practice. So this is looking at creating a culture of measuring what matters from outcomes to accountability. So when we look at outcomes and its impact on clinical practice, I think it's important that we have a system where we do good data collection. We analyze this data collection to reduce the risk, and then we reduce mortality. And it's important to remember that probably outcome measurement is probably one of the most important things that has helped in defining and improving healthcare management. When we look at accountability, on the other hand, it is hoping that it will help improve ethical behavior, put in a culture of responsibility, help patient-centric decisions, and very importantly, I think in the context of India, we look at how we can get cost-effective treatment which people can afford. So I'll start with with the outcomes, and so I would look at one of the prototypes was thalassemia. So we started bone marrow transplants in 1986, and we did our first transplant for thalassemia in 1991. You remember from medical school, thalassemia, the children present with transfusion-dependent anemia, there's no medical treatment available, and the only treatment is a bone marrow transplant. So we first analyzed our data about 10 years later. We had about 120 patients, and what we found that was roughly about 60% of patients were getting cured. And on the right side is actually worldwide figure. So you have a classification. Class 3 is the worst risk possible. Now that is about slightly, we were about 10-15% lower. Now we wanted to look at this further because 70% of our patients in India are class 3, and that is because they do not get adequate transfusion in the country, they do not get adequate chelation, and so it was important for us to try and see how we can improve on this group. So we analyzed the causes of death, and we found that majority is what is called as regimen-related toxicity or due to the conditioning regimen that we gave. And so we designed a new regimen where we replaced busulfan with another drug called triosulfan, which was luckily available in India, not much used abroad except in Europe. And what we managed to show at that time was with the use of a triosulfan-based regimen, we managed to push up our outcomes to almost 80%. So this meant that from about 40% with the original conditioning, we managed to bring this up to 80%. And going forward, this is data over the last 20-25 years. Over the 700 transplants, we have managed to keep it at 80%, and triosulfan is still maintaining a survival of about 85% in a large cohort of patients that we had. We didn't but forget about the other ones, the class 1 and the class 2. Initially our data showed that 85% were being cured. We felt that that was not good because they were actually considered low risk. And so we switched over from oral busulfan to intravenous busulfan, and with this toxicity came down further, and right now we are sitting at a survival of about 97%. So over a period of time, you have to use outcomes to innovate, change your strategy to improve survival, and I think very importantly, keep measuring it from time to time to ensure that whatever you've achieved, you manage to keep going over a period of time. The second is about aplastic anemia. Now, I'm sure all of you remember this is a patient who presents with pancytopenia and empty marrow, very common in India and Asian countries, and roughly about 80% of patients with severe aplastic anemia would die within 1 year of diagnosis if not properly treated. So we did our first transplant in 1990, and we started as convention with the regimens that were being used in Europe and US. This is a combination of cyclophosphamide with ATG, but we soon realized that they were not doing that well. We had rejection rates of 25%, and that is because patients were coming late, they were multiply transfused, they had infections. So if you look, the overall survival was sitting at about 50%. So over a period of time, we have actually modified our protocols, and now we have a different protocol of fludarabine with cyclophosphamide, and we managed to push up our survival to about 75%. And importantly, if you look on the right side, if you had a patient that you could take in early for transplant, you had more than a 90% chance that you could cure this patient of the aplastic anemia. And now this has become a protocol which is actually done by all transplant centers around the country. Now we managed to cure them, but an important problem still remained. And that is something what is called as chronic graft versus host disease, where the donor cells that have come in are reacting against the patient's body. We had about 40 to 50%. So we decided to look at a new strategy of using cyclophosphamide, which is a very cheap drug, and we showed that we were able to reduce the incidence of chronic GVHD from almost 60% to 22%, and right now we have a randomized trial going on comparing both in our institution. Going further, closer now, one of the problems with transplant is that roughly only about 30% have a donor, and so what do we do for the rest? And so over the last 10-15 years, what has come up across the world is the use of haploidentical transplant. So for every patient, either their parents, siblings or children will definitely be half matched, because that's how HLA is inherited. The problem with that is it was very intensive, a lot of use of toxic regimens, and because of that, when we had to use it in older patients, it was very difficult, and so our outcomes were only about 30%. So we decided to look at a new approach which is called as alpha beta depletion, where you take in the graft and you actually give only the cells that you want and try and remove the cells which are not good, which are the T cells. So we've done about 20 patients, mean age of 59, the oldest patient being 74, and was actually one of my professors who had acute myeloid leukemia, and now the survival is sitting at about 60% with the use of his approach. So I think we always need to remember, even if you are comfortable with something, if you are not able to achieve the best, you need to keep asking, what can I do to become better, and what can we do to improve the outcomes? When we look at accountability, I think in India, one of the very important things is to be accountable to provide a treatment that is effective, as well as it can be applied to a large population. So we had a disease called as acute promyelocytic leukemia, usually presents with bleeding, and roughly about, if you're not treated properly, 60 to 80% would actually die. There was a drug called as all-trans retinoic acid, which was experimented for in Europe and the US, and showed that it could cure about 80 to 90%. The problem, it was 10 to 12 lakhs the cost, and that is, remember, that is in 2000. And which meant that almost 80 to 90% of patients who came with APML to us just could not affect treatment. They would go home and actually die. So we heard some reports from Varanasi. There was a Vaidya called as Balendu Vaidya, who actually was treating patients. He was an Ayurvedic Siddha doctor, and he was treating with arsenic. And we actually had one of our patients who went to him and came back cured, although he had other problems related to arsenic toxicity. So we actually obtained industrial grade arsenic. In our pharmacy, we converted it to pharmaceutical grade arsenic, got all the standardization and tests done, and finally we obtained help from the ICMR to conduct the first clinical trial. And this is what the clinical trial showed. So here we had a drug which had almost an 87% survival with single agent arsenic trioxide. What is important? The cost, which is only about 2 lakhs for the entire period of treatment. So we were the second after the Chinese to actually use arsenic trioxide for APML. We continue to use it now, and now most of the European and the US protocols have incorporated arsenic trioxide into their treatment protocol because of just the ease of treatment. Now there is, so the other thing was we had to make sure we could not make large-scale arsenic in our own hospital. So we had to hand it over to pharmaceuticals because they are the ones who can produce it large scale. So what we did was to hand over the technology to one of the pharma companies, but with the caveat that they would produce arsenic at a cost which is affordable to an Indian patient. And so they kept to their promise and came out with a cost of about 400 rupees for generic arsenic trioxide, while at the same time it was about 6,500 rupees for the original arsenic trioxide. I'll quickly move through. We are doing a lot of genomics, we are doing a lot of next generation sequencing. So when we do that, we need to remember that multiple people are involved. It is the doctor, the local lab, the lab which does so genome or strand, the report. It's important for you to get the report, and it's important to make sure that you do that in a timely manner. We had a patient with aplastic anemia. He had lung and liver fibrosis, which meant that most likely he had a disease called as dyskeratosis congenita. But we had to prove it because we were to make sure it's a genetic type. We will need to test the donor. So we sent this one. It showed a genetic mutation. We converted this to an in-house to try and reduce. So originally we had a donor who was matched, but when we finally tested it, the donor had the same mutation, which meant you cannot use that donor for transplant. So finally we checked, one sister was half matched, and we found a second donor, a sister, who's again half matched, but does not have the genetic mutation, and that is the person that we are going to go forward with as a donor. And finally, so timely accurate reporting and then appropriate action on these reports are very important in terms of accountability. And in the end, I'll just talk about, so these were a group of 5 patients who presented with transfusion-dependent anemia, low blood counts, and all of them came to us for a bone marrow transplant. So when we set the next generation sequencing, we identified a mutation which is called as dorsal hematodiaphyseal dysplasia. So there were no other features to suggest a congenital bone marrow failure. Now when we looked at it, this mutation actually causes disturbance in the arachidonic pathway, and so is amenable to treatment with low-dose aspirin. So these patients were all just started on low-dose aspirin alone, and this is a profile of one of the patients who went through. So this is in April that we actually started, and if you look back, by about July, they had become stable, and in 6 months, they had actually had normal blood counts, and they continue to maintain normal blood counts for the next 6 months, for the next 2 to 3 years. And all 5 patients who had actually needed a transplant, we actually deferred transplant in all of them because they were actually doing well with just low-dose aspirin alone. So it's important when we look at next generation sequencing, we have the accountability to make sure that we interpret it rightly and we use the interpretation rightly to provide what is best for the patient. So I'll stop by saying that study outcomes are a very important part of quality management. It helps in improving treatment pathways and ultimately patient survival. Accountability is important for improving pathway care and ensuring that appropriate times for both providing diagnosis and treatment. Thank you for your attention.
Our next speaker is Dr. Mathew Cherian. He's a well-renowned international interventional radiologist. He has multiple training programs and fellowships, winner of multiple international national awards. He will now talk on how he went from a clinician to an HOD to a mentor for the next generation of doctors.
வந்துட்டுமா?
Can I run it off my pen drive? I don't know. We sent it by email, we loaded it in the morning, we played it. Can I do this? Can I connect the pen drive?
இல்லை நான் வாக்கு தான் கரெக்டாக கட் பண்ணுவேன். ஸ்டார்டிங் இது எல்லாருக்கும் பார்த்தாங்க இது பண்ணுவாங்க. ஓட்டும் போட்டு என்ன இருக்குது? கார்டு இருக்குது, 2 கார்டு இருக்குது.
Can I ask a question? Question.
சார் wait.
Sorry, where's the problem?
கேமரா ஃப்ரேம் மாறுதுண்ணா. யாராவது ஏகார்டில் போட்டிங்களா? இப்படி அது இடத்துல வருங்க. அந்த தனியாக அந்த காடை மட்டும் இருக்கலாமே. ரெக்கார்டிங் முடிச்சா அப்போ மறுபடியும் எடுக்கிறீங்க. எடுக்கலாம் அப்படியே இருக்குங்க. இல்லை அந்த கார்டு மட்டும் தனியாக எடுக்கலாம். அந்த கார்டு இல்லை எடுக்கலாமே. எடுக்கலாம். ப்ரெஸ்ஸி சொல்லுங்கள். ப்ரெஸ்ஸி எடுப்பாங்க.
Since we're a little bit delayed while they're loading up the slide, I'll just ask some questions. Dr. Biju, we see how you came up with your outcome, using an outcomes to change your treatment. So for a lot of young hospitals, what they see is that right now clinical audit and outcome audit is now not very well done. So how do you propose that they would start on their journey of establishing a good clinical audit and outcome practice?
I think to have a good clinical audit and outcome practice, it is important to make sure that the data is captured. So I think digitalization is very important because that is the only way data is going to be captured. And if you can capture data, then only you can look at an audit. So I think when any hospital starts, I think it's important they put in a way by which whatever they are doing, that data is captured. Once the data is captured, then 3 years, 5 years down the line, they can look at doing an audit, looking at what are their outcomes. Probably they may have small numbers, but that is still enough to compare against whatever is the benchmark, either in India or in the world, and then see how they are doing. So I think digitalization is very important. If they start with just doing paper forms, it will never get there.
Dr. Palaniswami, can you just talk to us a little bit about what innovations can you see at the bedside?
I think this is very relevant today, and many other times we learn many things from the patients. When we talk to them, find out, they guide us For example, if you take it, any research comes from the point of view maintaining data. For example, one patient came to me. That is the time that I was doing all cancer surgeries, and gastrectomy for cancer stomach done. No wife did not come to see him for 12 days. And later when I asked her, she told me, and because she has to run the watering the field and look after children and feeding the cows, so my responsibility so much I cannot come out and I come. That made me to look at, okay, why not we go? That way, that to recover them faster, to get back to routine work, we started a laparoscopic surgery and starts with gallbladder, and we moved on everywhere. And then today, when one patient came with a married 3rd month pancreatic cancer, and that is the time that minimal invasive will help the patient. We went for laparoscopic operation. It was the world's first time we could do it. That way, this minimal invasive promotion is because of the need and necessity of the farmers or laborers, and that way. Now we did it for laborers and this, and now today all type of surgeries have become. So the innovation, it is a need of the people. Also made cost effective also innovation. Indians today doing it affordable way. Whole world looks at India as a surprising way doing it. And high tech, it should be affordable to all the majority of the community in India. That the Indian surgeons or doctors are doing it very commendable way. Even Western countries look at India. Even China once said in Shanghai, Indian wants to China because Indians are doing it cost-effective manner, very reliable. So innovations learned from the bedside examination that we have to go through them.
Thank you. I think he's ready now.
Yeah. Sorry, that's not working, so I'm right in the front of you. So I'm Mathew Cherian. 150 million years ago, the dinosaurs ruled the world. At the same time, the birds also existed. But years later, the dinosaurs would disappear, but the birds continue to exist. And therefore, we need to ask ourselves this question. Why did the dinosaurs perish, but the birds survive? They reproduce faster, but the dinosaurs laid eggs once in a couple of years and took ages to grow. It was the same problem that we had with Ayurvedic medicine. Ayurvedic medicine existed 3,500 years ago, and when Sushruta was practicing this, the Western world were barbarians. And yet allopathic medicine would grow in thousands and millions all across the globe. And at the same time, Indian form of medicine was just a minority, and we ask why. And that's because we refuse to mentor and train. We believe in small gurukuls. Look at nature. You know, the plants produce so many seeds, they multiply, and we teach in hundreds, thinking it multiplies. But mentorship is much more than teaching. When I was 45, I was already well known. I had a lot of awards already on my name. And I was teaching, and I was content with my growth and the students had treated. I was also the HOD of radiology at that point of time. I was moving fast ahead. My colleagues were rather slow in catching up. The difference only kept increasing more and more. And I thought I was happy, I was content, the department was doing well, our reporting was good, and I thought it's my hard work that is making me grow, leaving the others behind. 15 years ago, a consultant of mine met me and asked, can you make me a department, a division, like you developed IR? That's the first time I realized that I was a blind leader. And what do I mean by that? I had climbed up a peak and positioned myself in a place where nobody else was able to reach. And therefore I realized I had to become a ladder to help people reach the top. And therefore, mentorship is the transformation of a metamorphosis of a leader into a ladder. The first thing was calling people, finding out what their dreams were. The second thing was giving direction to their dreams. And the third thing was actually talking to people who did not have dreams and give them a dream in life that they too could be channelized, and then give you 100% to make that happen. So a ladder is not easy. Becoming a ladder, you use your expertise, your talents, your influence and time to help people reach the top much faster than what you ever did without losing your identity. Don't do it for praise or gratitude. Some climb on your steps with gentle feet. Some will trample over you. And some can be so careless, it can be extremely painful. If you want a mentor, do it because it gives you a purpose in your life. Now then, everybody wanted to be a winner. Everybody wanted to have an identity of your own. Everybody wanted to feel specially cared by me, and also they all wanted a good work-life balance. It is difficult, but you try to make that happen for them to succeed in life. What are the barriers to mentorship? The first thing is negative thoughts. The first thing that often comes to the mind is this: why should it be so easy? Because I worked so hard to come to the top. My boss was so difficult, so why should I be kind? I ignored my family to grow, so why a great work-life balance? I may lose my identity. I remember the past hurts, and therefore I find it tough to forgive, and so why help at all? Once you cross these hurdles, only then are you ready to mentor. Otherwise you fall and you take your mentee down with you, and that can be destructive. And it's not easy. The road ahead is difficult. You will sacrifice your family life, your time. You'll be criticized for partiality, criticized for not helping everybody equally. But if you're clear that mentorship is survival, your final reward is honestly very, very great. So to be a great mentor, you have to give unconditionally, even if it hurts. In 2014, we were a happy group. We were doing well. I was the one boss. There was nothing that was difficult to decide. We reported together, we did things together, and we were happy. But the fact is, we were a plateau. We were not heard of. Nobody knew about our department at all. So I decided to break things up a little. So what did we do? We broke our happy groups, created subdivision, gave leads, and told each one of them, go ahead. Some were happy, some were terrified, some were totally confused. But the key fact they all had to learn: to succeed, you have to change from a general radiologist to give up a lot to become exceptionally good in one area. And that's what I did for them. And that means a lot of insecurity within, which we had to somehow support and make them grow out. But they need to transform further. They need to transform from someone who sat before monitors and reported and become clinical partners, to engage with clinicians, to evolve to become people who understood the clinician's problem deeply. So the step one, therefore, was to open our doors, to make sure we got everybody open their doors into areas of their expertise. We created an environment which was conducive. We had places for the consultant to sit and talk and discuss with the clinicians. There was no time fixed for that. In the end of the day, what did we achieve? A phenomenal relationship of trust, of mutual respect and dependency. But this was not the end. What if AI would finally be so good that the clinician will actually throw us in the dustbin and walk ahead? So it is important for me to develop the department that was future-proof. And therefore, we created something that was a strong protection. We distributed interventional radiology into every subspecialty because finally, therapy needs people to do it. So we decided to create clinics for people. We created rooms and clinics where they could see patients and engage with them and to talk to them and finally network with the patient, with the families, with the referring doctor and work along as a team. In 1991, we started a clinic for interventional radiology. It ran perfectly well. We used to see patients. When they came, we examined them. We related, we did whatever imaging was necessary. We performed procedures. We admitted the patients. We did follow-ups for them. We discharged them, and anything and everything that a proper clinician would do. And then we developed a system of educating physicians and patients, and in 10 years, we were clinical partners. And that was in 1991. It took 20 years for the next change because I was blinded. I didn't think about the others, but we set up clinics for abdomen, for fetal, for MSK, and finally all of them started working like finely geared machines. They would do a diagnosis, they would help plan the therapy with clinicians and related specialties. They would counsel the family, they'd counsel the people and do whatever interventions that was necessary for each subspecialty group, and this truly made us secure and improved for the future. What happened? The many pawns finally grew up and become kings. They became leaders. They are known all across the country as brilliant specialists, and they became experts in their subspecialties. And everybody today is a winner in my department. What are the greatest challenges in implementing this man? The HODs. They need to change. And they need to change and evolve every day. Why don't they change? The first thing is the fear of losing your identity. I may become insignificant, so I won't train or build anybody. And another one is AI. Why should I bother? I'm going to pass out before it affects me, so I don't care because it won't affect me, and so I'm trying to live a life which is temporary. So technically, never forget history. When I was a kid, there was a company called HMT that made watches that ruled the country. They disappeared when Quartz watches came and HMT did not evolve. It is the same thing today with diagnostic general radiologists. A time has come that you will die if you don't evolve. If you don't take up AI, you will die, and therefore to survive, you have to become a subspecialist who just only doesn't do diagnostic work with intervention. So the choice of being a dinosaur or to become a king or to transform your department and create kings lies in our hands. And to me, that is mentorship. My chairman will say, I've heard that nothing can grow under a banyan tree. It's a lie. The banyan tree can part its branches, that you can allow great things to happen. I close with the beautiful words of Steve Gobert, who sings that song and says, I am tall when I am on your shoulders, and you make me do things much more than I could ever do. So basically, the truth is this: you can achieve the impossible for a team if you decide to take up this as your role and a duty to build people up for the next generation. Thank you.
Wonderful, Dr. Mathew. You have illustrated all the trials and tribulations of a clinician going through the years and the challenges that you face and how you overcome them. I think now we can take some questions. Maybe I'll start with Dr. Mathew. When you have smaller departments in smaller hospitals which are not so rich in it, how do you propose they can do things like what you did? Certain problems that they face. Do you go back to your quality indicators?
Yes. So I think however small the data be, you have to build up. So if you look at what we had, our thalassemia data we built over 10 years. So it's because initially when we started, we were doing 1 transplant a year, nothing more than that. So I think you have to start small, keep steadily building up. But I think very importantly, when you do build up, you focus on the areas which are of relevance. So trying to do every disease, every subject will be difficult. So you look at which are the ones where more patients are coming, which are the ones where it's more relevant, and then you use your quality management systems to help build up that data.
I think that's an important lesson. Use your criteria to decide what is your pressing problem and work on that. So wherever you are a small hospital, large hospital, an academic institution or a clinical department, you can still improve based on data. Can I ask Dr. Palaniswami one question? When you do ward rounds, how do you, if you feel a person needs a reprimand, during the ward round, you find a problem and he needs to be ticked off, how do you do that? In the ward round, or what do you do?
And it is knowing the patient to fully recovering. It is not that we make once or twice rounds, that is the time seeing it. And we have to be in touch with the patient such a way, even the slightest problem, information has to come to us. We may be operating it, we may be in a consulting outpatient. The ward rounds, morning or evening is the compulsory taking decisions. In between also, bedside information will be coming to us all the time. Now those days we have to depend on patient relatives or the staff nurse. Now the technology is such a way and the patient can communicate with us. For example, if it is an ICU patient, that patient, if anything important is attended, or patient can go. He need not go there to look at. If necessary, will go. So bedside examination means keep constant follow-up of the patient for 24 hours. And that's why the teamwork is more important, not an individual. And team is such a way they trained leadership, now we also spoken, so that our next level, junior consultant, next level is a trainees, they will keep on it. So the round sitting does not mean like a boss going morning and evening. It is a bedside means knowing, they keep on touching the patients, progress morning to evening, next day 24 hours. That's the way it is. The decision of particular day also matters. It is not during the time. And now it has become an intensive care. Patient is a ICU or ward. Going home also we are following now. The exam patients, and we have a remote monitoring. Patient keeps on touch. And periodically nowadays daycare has come. Patient discharge same day. Next day morning call goes to the patient. How is your progress? Because you have taken a food. How is the pain and everything? And we keep your juniors to keep on touch with the patient. So today bedside examination goes remote level. And it is not that personally looking at bedside examination comes from the patient information. You got to give all information to them, educate them, then they give information.
I brought the question before board, Dr. Mathew and for Dr. Palaniswami. So I think Dr. Mathew said talk about doing mentorship, going to super specializations in the future. Now, what do you do when a doctor says, I don't want to super specialize, like in order surgery, I don't want to be a colonic surgeon, I want to do diabetic fluid, I want to do gastric surgery, I want to do thyroid surgery. How do you inspire them, or is it more of a culture fit?
Yeah, very important is to make it is today, it is a highly specialization now. When I took it to medical industry, I make it in such a way that, and it is so, a surgeon should take interest and going in. Unless until he focus somewhere like you suggested, it cannot become a leader. Everything you cannot do. Master of all subjects impossible today presently. And better after basic training in medicine or surgery, one has to choose their own specialty. And after which, and leader like one of us who trained in a particular field. For example, I became a gastrosurgeon. Now today gastrosurgeon is not a specialty. We have to be upper GI, colorectal, HPB, and bariatric, hernia, like differently. Even again, if you go to Korea and Japan, they become esophageal surgeon, gastric surgeon, like. So it is, as you said, choose one field, work on that, pick it up. And seniors who are leading it, they have to mentor, guide them, and give the opportunity to develop it. And everybody can't learn everything, but they can focus somewhere, learn. And the teaching institution and the medical colleges or private has to take up that leadership. Today, it is highly specialized focus, then only the quality of care will be.
I would like to differ completely from what was said. So, you should read this book by Robert Schultz on the making of Starbucks. One of the things he says, if somebody's culture doesn't fit with your organization, ask him to leave early. Otherwise, he destroys the culture of your department. So in our department, even when they join, I tell them very clearly, you have to subspecialize. Decide right now, do you want to go in that journey or not? If you're not going to do it, as well quit now. Because otherwise, he creates a coterie around him who will start telling, I don't want to subspecialize. So I always thought you try to, cajole, no, it doesn't work. He says, because it's destructive. So in our department, it's very clear, when you join, you say, we got a center in Erode, we got a center in Sulu, you don't want to subspecialize, we'll give you a job there. But if you come to the main center, you are an apex, and if you want to be an apex, you have to subspecialize. So we are very clear, we make them understand the philosophy of the department, we get them to know right now. Unfortunately, in my hospital, many departments have not so specialized, but we have done it, and that's the secret of our success. We have done extremely well, but we don't give them a choice.
They all have to be team players. And I think we have had a very interesting session this afternoon prior to lunch. All three speakers have illustrated the principles of leadership, medication, and also quality framework in all whatever that we have done to address the problems that you face in your daily life. I think with that, we will conclude this session. I think each of them has given their own experiences. You can now reflect and see what can apply to your own settings and see how you can improve your work every day. Thank you. Thank you to all the speakers.
Thank you so much to all our esteemed speakers. And I'd like to invite our speakers and the chairperson for a quick photograph. You have to move towards your left. Thank you so much. And I think the last message given by our chairperson is the reflection. And I think we all need to reflect upon the learnings that we take from this conference and see how we can apply it to our own settings. So from bedside to wisdom to leadership journey, this session has truly embodied the healing touch